nothing from me personally about metrics unless it's something that's being brought up. Okay. Because I want us to really focus today on changing and facilitating our healthcare so we can do what's best for our kids and our providers, and to really work on the health of our children in the state. I don't know, y'all have agendas? Chris is passing it out, okay. Bear in mind that I'm living this personally with Children's Hospital, so there's a lot of things that go on within my own personal world as well, and so I've got a lot of ideas, and we'll talk about them, and I don't pretend to have all the solutions, and I want to definitely hear about the experiences that folks are having within your own sites, and I'm going to be taking notes for me as well. So please do not feel afraid to speak up. There were very, very few wrong answers. There's a lot of right answers, and there's a lot of adapting and tailoring that folks are going to be doing within their own sites. So I think this is going to be a great discussion. You'll see in the agenda that we're going to start off by talking about population management and staff roles and teams. And the reason I wanted to start with those two topics is because I think we hear a lot about these terms, but to try to get them onto the ground is something that we don't talk as much about. And there are some things that I've read that I'm going to present and share with you, and you'll see some of those, and they've got references. And there are some things that we're living right now that I also want to share with you, some things that I personally discovered in the last few, I don't know, days, weeks. But in all seriousness, everybody's got experiences there, and I definitely want to hear your experiences as well. So definitely don't be shy. I will walk around. Please feel free to ask questions at any point you feel is necessary. I also want to recognize Stephen Tongi and Rhonda Hill, who are here from Qualis, and they've agreed to answer questions if directed. But they've been a tremendous resource as well. I'm glad to have them here. Okay. So here's your agenda. And we also want to acknowledge the support of Arkansas Medicaid Division of Human Services. They are supporting our time to help us facilitate this meeting, as well as support for giving peer-to-peer support for this PCMH. All right, population management. What does this term mean to you? Yeah, I'm going to ask questions. Y'all heard this term, right? What is it? What does population management or a related term, population health, mean?
It's like a big picture of a group of patients.
Of a group of patients, right? So it's a group of individuals. And what does it mean to manage a population? So manage population, so you're managing a group of patients or a group of individuals. And what are you trying to achieve when you're doing population management?
Overall, better health.
Better health for everybody.
Yeah.
Right. So one thing I have discovered is that many of us in this room are clinically trained in some clinical field, and all of us work in clinical field, and all of us work in the clinical field. The clinical model that we've all been trained with is that, is there any difference between a microphone and a microphone?
We can hear you.
Okay. So for all of us who work in a clinical setting, I think that the fault of the way we were all trained is that we were trained to treat the person that's sitting in front of us. I think we're less trained to manage the health of somebody who isn't sitting in front of us. But when we're talking about the health of individuals, we have to think about all the drivers of individuals' health and not think about just what's in front of us. And that's actually, like, when you really get down to the nitty-gritty, that's a lot harder than it sounds, because we're so ingrained to treat the child who sits in front of us with an earache. And so what we want to do is think about not only the idea, but how to get to the point where there's a process, a very consistent process in our practices, where we're really treating the entire health of the child and family, and not just the child and family So that's really about what population management is all about. But I want you to understand the importance of basic processes of population management, but then to be able to explain why it's important and be able to lead. Lead by example, lead by words, because this really is a big change for all of us. And it has to do with the way we're getting, by the way our processes are currently set up, the way we're trained, and frankly, the way that we're getting paid. At any point, if you all have heard some of this stuff already, feel free to tell me that you've heard this and we can move faster. But I figured it would help to kind of go back and look at a few slides and talk about some of the concepts first. Give me a sense of how much have you all talked about this within our practices, kind of the wards population management. Again, we're going past the metrics. Like, is this concept you're familiar with, or is this brand new, or somewhere in the middle?
Pretty new.
Is it new? So this is timely then? Okay, good. Okay. So I asked a question, what is population management? And you'll hear a related term, which is population health. And I think you'll hit the nail on the head. It's the health outcomes of a group of individuals. But medical care is only one of many factors that really determines health. There's public health issues, including immunization programs, for example. We all know that social environment drives a lot of patient health, and it goes to things like the conditions that our kids live in, transportation, recognition of symptoms at home, et cetera, et cetera. And one of the things that I hear constantly is that there are so many things that we have a hard time being able to control. And I use that word purposely because I think that, especially since so much of clinical training starts out in the inpatient setting where you can control a lot of the processes, but since we all live in the outpatient setting, I think that we all know that in the outpatient setting, you don't have that level of control. And of course, I want you to get away from that word because it implies that we're trying to control the situation. And you can't control things in the outpatient setting, and that's okay. But I do think that there's plenty we can do to help facilitate improved health with population management. But we have to be willing to accept that there's only so much that we can control, and that's totally fine. Okay. But why do population management? Come in. Just lunch? Welcome. So why do population management? I mean, obviously the best answer is that it's just better health for everybody. Because of all the drivers that we have for populations, for the health of individuals. Better health outcomes, and lower cost. And if you're familiar with the triple aim of healthcare, you may recognize that the triple aim is to be able to achieve better health outcomes, which are things that you can measure at lower cost. But I also believe that population management will also lead to both patient and provider satisfaction. Because then you're really feeling like you're making an impact on, from a provider standpoint, you're feeling like you're making an impact on the health of a person, as opposed to sometimes we feel like we're going around this merry-go-round of situations. And of course, families love population management. I mean, just the fact that, for example, that you get phone calls out of the blue because you're reviewing something. I mean, patient families love those kind of out of the blue phone calls. That's been our experience. Okay, so this is probably one of the last kind of official, read the books type slides that I'm going to present for this section. So you'll hear about population management that we should have a patient registry, which means that you're supposed to be having a list of patients that you review and you follow. You're supposed to provide care coordination for every sense of the word. You're supposed to have multidisciplinary care teams. So another buzzword, but we'll get into teams a little bit more as we go into the afternoon. You're supposed to provide continuous care, which is a fancy way of saying that they should be seeing the same group of folks so that you get to know and establish relationships with folks. And you're supposed to emphasize health, behavior, and lifestyle changes. So this is less about the specific intervention that's going on medically within the office setting, but you then emphasize behavior and lifestyle changes that they can do within the home setting. Okay. So you'll see these written in books and articles and such. And I think the key for us is to be able to get into these and say, well, how do we actually make this happen consistently within the, within the practice setting? Okay. So this is when I start getting into the culture change that this really is. You're really looking at having regular and more proactive contact with patients. So the first question that people ask was, this is stuff that we don't get paid for, and I think that's a very valid and very important issue. But this is where we start getting into the upfront practice support payments and what we can use those for to be able to support these activities. And I think our payers will say, well, this is what we're paying you for, is that we want you to go out front and be proactive with your patient care. And, instead of paying piecemeal for phone care and paying piecemeal for, meetings, what they're doing is they're putting money up front and saying, this is what you need to do with it. But this also is a shift from encounter-based care. This is what I call as an encounter-based care. So a patient comes in, they have an earache, to care based on needs. And when I say a care based on needs, I'm talking about the needs of the child and family regardless of where they are. If you've got a child sitting at home who's coughing every night, so that child probably has uncontrolled asthma. But you don't know about it until the child comes in 3 months later and status asthmaticus, right? So, but the need for the child was to have that intervention done 2 months earlier when the child was starting to cough every single night. And we didn't know, and to make sure that we find out about it so we can work with the family to be able to intervene. So that's what I mean by saying care based on needs, not when we start to see it, and not when they come to us, it's when they need it. Okay. Support efforts to manage patients' own health. And you'll see a lot about self-management of self-management as something that you'll hear within the patient's own home. Now, self-management really came from the adult literature. You'll hear a lot about that when you talk about adult care. But I think the concept in pediatrics is very similar in that we need to be working with the caregivers and the families to be able to support better management at home. Okay? And finally, it's working teams, because every single one of us in the room has a role professionally, right? It's whether you're sitting up front, whether you're sitting in the back, whether you're sitting in a totally different part of the office because you're doing paperwork based on payments and billing. Everybody's got a role, right? But a family and a child, their role is to live. Their child and their role is to be healthy. And to be able to be healthy, they have to interact with every single one of us in this room. So working in teams means that we're going to take all of our expertise and all of our roles, and we're going to make it work together for the family. Now, I want to give one word of caution. Working in teams is not the same as delegating, right? Because, and I've seen this over and over again, is that when you hear about team-based care, there may be, one of the things to be careful about is, okay, well, we're in a team, so therefore, I'm too busy to do this, so you take care of this. And that's not the way it's supposed to work. The way it's supposed to work is that everybody works together, recognizes their roles, and make it the sum, and the output of a team is greater than the sum of its parts. Okay. Now that's a little, again, kind of conceptual, but we will get into that when we get into teams. But I want to say up front that when you work in a team, it's because you have to bring everybody together, but you don't use it as an excuse to delegate from somebody else. That's something that could be done effectively by another person. Just kind of be aware of that. And finally, I do want you to recognize that this is really a transformative process. And it's transformative because of the way we were trained and the way that we have been historically paid. And so it sounds good, but we really do need to be taking steps at a time. And I really do believe that our colleagues at Medicaid and our colleagues in our private payer colleagues, they really, really do understand this. And I think that I'm very, very grateful that they do understand this. And this is where we need to understand that relative to the metrics that we are asked to meet. We do have to meet metrics, but they recognize that this is going to take a lot of time. The steps are, there should be payments that support the time to be able to do population management. right, but that's there. So we need to now get into data registries. We need to prioritize patient needs, and I'm assuming that folks have heard about stratification or kind of assigning services based on what you think that folks actually need. And this is because when you're talking about a population, you can't take care of everything at once. There's just no way. So you have to prioritize and you have to go down so you can manage, taking little steps one at a time. Team-based care and delegation and reorganization. Again, we'll go into that a little bit later this afternoon. And the final bullet point here is something called reactive to proactive management. So Jeannie Van Cleve and colleagues, I actually saw Jeannie a couple of weeks ago. She's based in Boston. Kind of does a lot of similar work. And she and a group just had a paper published in Pediatrics. Actually, I think it's coming out next month. I just saw an advanced copy of it, where they just released the paper. And they went back and looked at a number of practices that have made the journey of practice transformation, kind of individual level. So we've worked at learning collaboratives within the last 5, 10, 15 years. And they went back and they looked at what happened to them 10, 15 years after they really started this journey. And the point I want to share from that paper is that they saw a change from reacting to everything, right? So like putting out fires all the time. All right, I got to take care of this referral that just came to my door. I have to, or this child's asthma is really well controlled. The child's been in the hospital 3 times, and they were like identifying all these fires, and they were better able to handle them, get a handle on them, and control the process. But over a period of several years, it moved from reacting to these kids who were coming in sick to proactive, which is that they were going after families before the children got sick. And this happened. This really did happen. It's a great paper. It's well described. And we can do all of this as well. It is going to take time, but this is where we're really trying to go. And that, I believe, is when we really are going to see better health care at lower cost, because that's at a point where we're really controlling the system and controlling health to the point where kids will stay healthier instead of us waiting for them to get sick. Okay? Because I recognize that we're all putting out a lot of fires these days, right? A lot of fires. And we will get to the point where we're not putting out all these fires anymore, and we can start preventing the fires from happening in the first place. We'll get there. It just will take some time, but this is a natural part of the journey. Okay. So this all sounds good, but I'm going to throw out these 2 questions, and I want to hear from y'all what you've seen so far. What are the challenges that you've encountered in trying to do population management? I mean, have you started? Do you feel like you're doing some of these aspects already? I know everybody's doing some components of these already. What are some of the challenges?
I'll get the group started.
Go.
I'm not shy when it comes to speaking. You can
Go.
be strong.
Yeah.
In my role as a PCMH coach, I see quite often clinics having trouble getting to their data. And I know we really don't want to spend a lot of time talking about metrics, but you have a lot of good content in your EHRs and probably not a lot of good reporting. So if you are trying to do population management, you need to get to your data. So for example, if I were to say, what is the average height of everyone in this room, I could do a little sampling, or ideally I could measure everybody and average everybody out. So
you took my next slide.
oh, that's sorry. Sorry. But anyway, so
I'm gonna come back to that, but I think that's well said. We're on the same wavelength, right?
Mm.
Yeah, I definitely want to spend some time thinking about data, because we've got it's some of it. I think you've heard this from me before. One of the things I hear is that please give us the data and we can figure out what to do with it. And I really believe that you have to generate your own data, because it's timely and you can vouch for the accuracy of it. And there certainly is data that you need to look at externally, particularly when payments are tied to it. But as far as actual population management, at some level, you need to at least be able to be comfortable with your own data. And, you know, it can be really massive or it can be really small, but you have to have some sort of data. What else? What are some other challenges?
Getting the patients to comply, that's a big one. We've already had trouble having patients come back in, saying, I was just there 6 months ago.
Yeah, so that's, I hear that quite a bit. I mean, that's very, very common, is how do we engage patients and families so that we're all kind of on the same page. I do think that some of it is that we want to be doing the right thing for families instead of doing it strictly meeting metrics, and I know that we all hear that. And so this is also why the metrics are not 100%. You know, I think that they're designed to have some wiggle room. I think that's a big challenge, and to be able to address those, one, it takes a lot of time, and two, it takes getting into the community or having family advisors that help try to bridge those gaps, and those are longer term, and those are longer term. And then ultimately, I think that I think from our standpoint as providers, we need to give up some of that, coming to see me to let's see what we can do somewhere in the middle. But that's, again, that takes a while. And I've seen improvements in those areas and practices, but they generally take addressing outside of more community outreach rather than trying to do something differently. Other challenges?
Just on a very basic level, trying to get patients to follow an asthma action plan and give their flow vent every day, twice a day.
So I would call that health. So there's a number of terms for that, and one of the terms that you hear is health literacy. So, and do they understand? You're right. So do we have the time? Where's the disconnect about either understanding or adhering or motivation? It could be right. It could be any one of those issues. And there's all sorts of literature and techniques that people use. Motivational interviewing is a term that you may have heard. Community-based supports, home visiting, so on and so forth. And it's a lot of stuff, and I think we have to, and there's no one size fits all. But that's, again, a step that we take that we weren't necessarily able to do before. What else? Come from the back of the room. Challenges? Buy-in from folks in the office? Or like our folks on board with trying to move deliveries in this direction? Other thoughts?
Another one maybe is vision. It's hard for people to understand today's medical model versus where we're trying to go tomorrow, and how population health is a new capability. It's a new skill set. It's not something, it's not working harder for what you did yesterday. It's changing.
If we look at healthcare systems, that includes other countries that have been more successful at the triple aim of kind of either equal or better health outcomes and lower costs. And we all know about how the U.S. healthcare system has runaway healthcare costs relative to the rest of the world. Pretty much all the success systems are doing successful population management. Their data's better, their infrastructure's better. We have a very different system that has really rewarded technological advances and really less prioritized population management. And this is why we're all going in this direction now. But I think that Stephen's point is well taken, that I think folks really know this in theory, but whether they know that I think that understanding that this is really where the healthcare systems in the United States are going, basically because we don't have a choice. We've got to get all this stuff under control and make, and do more with less. I think it is a question is that whether everybody really understands that's where it's going. So, and you may run into that kind of buy-in of like, well, why should I do this differently? And sometimes it's not because we don't want to do it, it's because we don't know how. What about successes? I want to hear about successes. What have you done so far that is population management as a success? Doesn't matter how big or small it is. I want to hear about successes. So, like, what have you uncovered by looking at a patient's chart before they come in? What are like just things that you've uncovered? You said, well, you know, if I hadn't done this, I wouldn't have. No. You know, we're uncovering all sorts of things. I know folks have uncovered stuff.
Kid hasn't had PFTs in a year and a half.
You know, exactly. Did you find, for that particular trial, or maybe some other children, would you find stuff that you wouldn't have found if you hadn't said, you know, come on in and get it done? What else?
Well, I think we've discovered that we still had patients who didn't realize they were open on Saturday. Something as basic as that, you know, when they're calling them and saying, you know, hey, before you run off to the emergency room, give us a call. We have Saturday hours. And we think, how could they not know that? But some don't.
Wow. Now, how did you achieve that, or how did that come about? You know, was that something was it that you started telling folks, or just kind of reinforcing that you were open on Saturday, or what?
Just reinforcing. They've always been open on Saturday,
Right.
so it's just reinforcing it when the care coordinators, Jan and Misty, were making initial, you know, outreach to our patients.
So like basically reorienting. Great. What
Right,
else?
we get the reports from Children's or Baptist when someone's been to the ER.
Uh-huh.
And so the high priority ones we definitely follow up on. And ask them, you know, did you know we were open then? You
So
know,
it's an opportunity, right? So just bringing them back creates an opportunity to educate about access.
Right.
That's right. That's great. And I do think that if you create opportunities to discuss and see and contact and touch families, that these sorts of things can happen. And I think it's all about creating more touch points for families to be part of the healthcare system. Other successes? Yeah, I mean, from our standpoint, we're seeing kids that, you know, medications that weren't filled, you know, social situations we uncover and they get flagged because they're not filling in their health supervision visit. So we start digging and start looking at the ER visits, and we start, you know, all sorts of flags start getting raised. PFTs, PFTs, emergency room visits that are flagged for us to be able to say, you know, hey, something's out of control. And I think these are still reactive. You know, I think we're not as proactive as we want to be, but I think that, you know, these are all little steps that individually do start to add up on a population level. So this slide is about population monitoring, and Steve, it's a little bit of my thunder on this one. It's okay. I appreciate it. This really starts with the patient registry. I think folks talk about registries quite a bit. At some level, we have to keep track of our patients. I think that's really the bottom line. You start by also asking, where does the registry data come from? Because, I mean, there's certainly, if you get a list of patients for an payer, then you're going to get payer data. Right? If you generate a registry based on your own EMR, then you get what's in your EMR, which may or may not necessarily correlate with what's being billed. Because of the lag, or sometimes the billing is incorrect, or sometimes it's correct, and the payer, you know, something happened on the payer side. But at least if it's coming through the EMR, then you can go back and look and verify what's really going on. What's the format of the data? And what I mean by that is, are you getting a list of paper, or do you have an Excel spreadsheet that you can sort? And if you have an Excel spreadsheet, do you have people who know how to sort? And it's something we're working on locally at Children's. And then that actually gets into who monitors the registry. So what I'm suggesting is that, you know, you have your list, right? You got your list of patients. So one list that you're all keeping is high priority beneficiaries, and that is a patient registry. But people keep lists of patients with asthma. Those of us in the room that did the asthma project with us. You know, children who have ADHD, that would be another registry that some folks would keep. There's registries of children who have been delinquent on their well-child visits. I mean, you can create slice and dice registries, but you use that as an opportunity to go back and say, okay, you know, who's successful, who's not successful at getting the health care that they need. But what's important is that somebody's got to monitor the registry. You know, I think we see a lot of data, and then it's a question of what do we do, you know, so you have to look at not only the quality of the data, but also make sure that the data is actually regularly monitored. And that's really a really crucial step to be able to do population management, is that somebody has to be able to look at that data. And, you know, if you don't have somebody looking at the data, one of the steps I would suggest is make sure that you have somebody looking at the data, but also create that process and say, okay, you have to look at it this many times. These are the outcomes you want to look at, but somebody's just got to look at it. The next step is actually stratification and sorting methods. Anyone sorting their data right now?
Like breaking it down into
Good.
diagnosis, asthma.
Okay,
Yeah.
yeah, so you're breaking down the groups.
Yeah.
What I'm also thinking about stratification is try to order it and try to break down your data in order, some sort of severity. Is anyone doing
We
that?
talked about that.
Well, our system, we have a module in our EMR that will do that for us,
Uh-huh.
so I guess technically we are, but we did not go in and assign the risk score ourselves.
So risk scoring, I really do strongly suggest that you do some sort of stratification. But the thing about stratification, and I put sorting methods here, is that it's helpful to know how the people are sorted, because a lot of sorting methods aren't terribly accurate. Sorting methods, so you can sort based on any number of things. So the idea, in my mind, the idea is that you want to know who's going to use healthcare tomorrow, right? So whatever they did yesterday is already done. It's what you're trying to do with population management is what's going to happen tomorrow. And in some cases, prior use predicts future use, but not necessarily. Diagnosis can predict future use, but not necessarily. And there's a lot of things which predict future use, but it's not necessarily good. And so that's why sorting methods aren't necessarily all perfect. The adult literature has a number of sorting methods and algorithms that do, for the most part, a pretty good job in certain areas. One of the prototypes is that if you have an individual who has no health insurance, who has diabetes and is in cardiac failure or kidney disease, and has been in the emergency room 75 times in the last 2 years, and there are patients in the adult world that do this. There's actually quite a number of them that do this, and they account for a lot of healthcare costs. There's a very good chance that they're going to continue doing the same thing next year. You know, unless something really big changes, a very good chance that it's going to happen next year. So the adult predictive models, and I don't know if the sorting method that you're speaking of does that, but it's quite possible that it's going to look at things like future, you know, it's going to look at how many ER visits they have, how many hospital visits they have, what are their diagnoses, and they'll throw them all together or something, and they'll say, okay, this is what's going on. You know, okay, so this is somebody who's likely to be flagged as somebody who's going to go to the ER 20 times next year. And it doesn't really work all that well with kids. And because a lot of kids get better. Some kids don't, but a lot of kids get better. And a lot of kids get better as they get older, and some kids get worse. And what we're finding, this is some of the research that I'm doing separately, is that there's a small number of kids that use a lot of healthcare, and about 50. If you look at the top 1% of spenders in pediatrics, about 50% of their costs are going to inpatient costs. But only about 15% of them are actually getting hospitalized in any given year. So if you actually look at, hospital stays, there's also a really good chance you're not gonna get hospitalized next year. And if you only look at hospital stays, you're gonna miss about 85% of kids. So where's the rest of it going? Drugs, big one. You know, and I'm not sure how much you can do to actually control this cost. Mental health is huge, and I think it's not very well characterized because our mental health care system is very separate. And outpatient specialty costs is actually quite big as well. So, but as far as stratification, so if you look at hospital stays, the hospital stays right now are driving a lot of those risk stratifications, but those aren't necessarily the kids you need to focus on, because a lot of them are not going to get hospitalized next year. You know, one thing I'm finding in children's, like if you look at children's, is that the kids who really look at the risk are the ones who have about 10 appointments scheduled at children's the following year. So, yeah, because I've looked at those kids, and those kids tend to have multiple chronic conditions and get hospitalized quite a bit for the emergency room. But that just tells you that that's a measure that you can't, a payer doesn't know that information. What that means is that you may want to create your own. You can rely on pre-existing stratification methods, but ultimately you're going to have to put some sort of human component in to get exactly what you want to create. And we're not going to talk about stratification too much. I know there are many, many other places, opportunities to learn about risk stratification, from Andrews and Wallace and all the other resources we have. But I do want to at least mention that we do need to stratify, but you have to take the existing stratification method just kind of grain of salt. And I would consider things like the psychosocial situation, the other drivers, because that may drive healthcare use as well. We do know that that counts as a measure of healthcare. Okay. Any questions so far? I kind of got a little academic on that one. So you got all this data, it's sorted, it looks good, then what do you do with all of it? Oh, look at that, I actually just went through that. Okay. So this is actually the last slide for this. I want to talk a bit about processes because ultimately we're going to get a lot of data dumped on us. I mean, we've already got a lot of data dumped on us. There's a lot we can learn from the reports we get from Medicaid. There's a lot that we can learn just by looking at our own EMR registries. There's a lot to learn from just having alerts for patients. But how do you make sure that this actually becomes routine in your practices? And that's really what I want you to think about. When we talk about getting from here to there, when you're talking about going from a counter-based and very reactive to a population management, very proactive approach, there's a lot of little things that will go along the way. So what I want to hear about is just things that folks are doing in population management. What are the things that folks have done already? And I think this will just give us some ideas of where we want to go next. I mean, I want you to have the big picture, but I want to hear about kind of like individual things that folks are doing. Registry development, registry monitoring, stratification, sorting, action steps from your data. So for example, if you see a child who's been in the emergency room 4 times in the last month, do you have a process set up to be able to address that? Patient alerts. Do you have alerts in your EMR? Do you have alerts that when they don't come in? Do you have alerts when they come in? Do you have alerts in general? Do you send out postcards? Do you get phone calls? And so on. There are other things we have in here that I haven't put in here. Family advisors, family integration into your own care teams, community outreach, cultural competency materials, or things in different languages. What are things that folks have done? I want to hear about your ideas and things that you've already tried. Who's put together registries so far? I don't want to pick on you, but yeah, it's what kind of registry? What kind of registry?
Right now, we just have all of our PCMH patients grouped by their primary care physician. And so each physician's nurse has a list of these patients, and they are calling them, if they haven't been seen lately, they're calling them, getting them to come in, scheduling them for asthma rechecks, ADD checks, which we see them every 3 to 6 months anyway. But the nurses are on top of when these patients need to be seen again, and are getting them scheduled.
Great. So this also gets into the whole care team concept, and we'll talk about that actually next. But I think that's great. What else? What are folks doing?
Well, we just recently set up a new communication tool that, when the doctor, as they are doing their care plan, they can actually put in the next time they want to see the patient. And we have a system that so many days before it's time to call for that appointment, it's alerting the patient, and it's interactive, so they can either, call us or whatever and get that appointment made. And if they don't call within a timely, within the time for the appointment, we can reach out to them. And then we have a new reminder system where they can accept or not confirm, cancel, or reschedule. I think our biggest challenge is getting them in, and so we try to focus some efforts on maintaining, contact in every way possible.
So just to kind of go a little bit further, so you've spent, the initial steps you've taken are to set up more of a reminder system. How have folks reacted to that so far? What kind of, obviously, I'm sure it sounds like it's not quite where you want it to be, but I'm sure that there's.
Well, we just went live last week, so I don't know that the recall part has been used, but I do know that we're having good response with the part about confirm, cancel, or reschedule.
Oh, great.
Yeah. And we set up, you can do unique messages depending on the appointment type, because the appointment type is what drives it. So we have unique messages going out if it's a med check, or if it's a PCMH recheck. And like for the med check, we say, it's important to come in every 6 months. You may not get your refills if you don't. I mean, nicer than that, but, just sort of make it specific to the reason that they're coming in.
And how much is this automated versus like somebody gets on the phone?
It's 100% automated.
Great, awesome. Other things, data steps taken from data reviews. Back to the room.
And we could say that I've got Karen here that has called, Lord knows how many patients, booked numerous appointments, and our no-show rate has increased more dramatically since we've started trying to push these patients through. A lot of times you call and their numbers are changed, you have no contact with these people. Addresses don't even exist anymore, even if they filled it out when they just came in this last time. It's different the next time. Getting these kids in has been, because there's no penalty to them.
So in quality improvement speak, let's kind of get into quality. I'm going to put a quality improvement type hat on for just a minute. I think you've touched into an important point, which is we try to do something. We may have successes, but do we also create a new issue? And I think that's a very, very real issue. And I think it's important that when you're looking at something, that you look not only about did you actually achieve something, but did you create a new issue? And so the issue you've raised is that did you start clogging up your template? Because to have an empty slot is something that we're still fee for service, and to have an empty slot is lost income. So that's definitely an issue. What I've actually said for our, at Children's, with our patients, what I've actually told our team is, let's roll out the recalls slowly, because if we try to get everybody scheduled, our waiting time for a visit is probably going to go out to 6-7 months. We're already at 2.5 to 3, and that's actually good compared to where we were in the fall. So I would encourage you that as you start rolling things out, definitely think about whether there's an unintended consequence. And in quality improvements, we call that a balancing measure. And a classic example of balancing measure is if you're trying to shorten, say, if you have an admission for, let's say, asthma, and you're trying to shorten the admission time, and you get it down from, say, 4 days to 3, did your readmission rate just go up? Okay, that's a balancing measure. And so when you think about something you're trying, that's actually a reason not to try to roll everything out at once. You know, you always try to start something small, and you look and see if there is, and even if you're not necessarily measuring it, you know that something had come up, which is now your no-show rate's increased. And so you may want to roll it back and say, okay, well, what can I do to actually make sure that if you're going to recall folks, that they're actually going to come in? That's a separate conversation, and I think it's a great topic of conversation about that can get into reminder methods to, community engagement and kind of everything in between. But I think it's a great point. Thanks for bringing that up. Other processes that folks have tried, whether they've worked or whether they haven't worked, is do what you want in that table.
I'm gonna talk a little later, but,
Okay.
so I didn't wanna say too much, but I know our patient center medical home coordinator, Kim, will flag all our charts, so they'll have to order beneficiaries and just tell us their chronic illnesses that need to be addressed, and it's been good to just kind of keep us organized and on track.
So you've got a designated person.
Right.
Yeah, perfect. And I think that's the key is that as you roll out changes with population management, that you do have to define your process and assign roles to people and make sure that they're accountable for to getting those things done, because it really is a change. It's really a change from being reactive to proactive. Being proactive means that you've got to be able to set that process to be on top of things before they actually happen. We're on time. Are there any questions, observations? So this is a segue into teams. Anybody who's like stretch, run to the restroom, just go ahead. Our next break is going to be at 2:15. So I'm going to confess about this presentation is that I first did this presentation about 8 years ago. But it's a topic, and I haven't revisited it too thoroughly until the last couple of weeks when I started kind of looking back into it. And you'll see that the slides I present are a combination of what I presented, 8 years ago, and some kind of the newer literature and kind of thoughts. But the concepts of teams really have not changed. I think the understanding of what teams can do in healthcare continues to evolve. But I want to start with the concepts of people working together. And I think that is, so like there was a model which is sometimes romanticized of like the solo practitioner, solo doctor who did everything by him or herself, in a one room, in a one room office. But those days that's not a common medical model anymore. I mean, we really do work in teams these days. My dad, by the way, was one of them. I don't know how we did it, but we did. Gave the shots, answered the phone calls, and so forth, but I didn't take over his practice, and that's probably why. True story. Okay. So, a little academic-y stuff. What is a team? So a team is a small number of people with complementary skills who are committed to a common purpose, a set of performance goals, an approach for which they hold themselves mutually accountable. I'm going to break down this definition a little bit. A small number of people, so that means it's got to be manageable. I mean, there are people who write about just what is the optimal number for a team. And so if you've got multiple people in a practice setting, then you do have to break it down to smaller teams, because you'll never manage a team of 20 people, when you're trying to change these kind of processes. A small number of people have complementary skills, right? So you've got to look at the skill set of the people within that team who are committed to a common purpose. Okay, so everybody's looking at the same thing, set of performance goals. And so when you're looking at evaluating teams, that there are metrics that you use to be able to say, okay, well, we're actually doing what we need to do. And an approach for which they hold themselves mutually accountable. I can't emphasize enough that when we're talking about teams, that everybody needs to be on the same page. When you look at leadership in teams, now leadership is a whole other discussion. That could actually be the topic for another learning collaborative session. But leaders and teams, which are really intertwined with each other, the leader may set the tone for where the team needs to go, but they also recognize that leadership is not about saying you go there. Leadership is making sure that the group is fostering mutual accountability for everybody in the group, which is a really simple way of saying, a more complicated way of saying something very simple, which is that if everybody ain't on the same page, it's just not going to get done. And you can think about how many times that you may have been in a situation, hopefully not in your present place, but you're in a situation where like, okay, well, why is this leader saying this? It just makes no sense to me. Well, I mean, that's an area where the team is not quite working and needs to be readdressed. For a team to work well, everybody needs to buy in. Which is why I want to go through this, because you'll go back to your practices and you're going to be, in a sense, a leader for saying, you know, this is where we need to go. Okay, but everybody needs to be buying into the same vision, and that's what we're really working on with leadership. So, characteristics of a high-functioning team. A team shares a common purpose, okay, so they know what they want to do. They agree on where they're going. They agree on the performance goals. Okay. They then define a common working approach. So, you know, they know how they're going to do things, and they develop a high level of complementary skills. Now, notice that I also said the word develop. Okay. Develop means that teams can be developed, teams can be nurtured, roles can be defined and nurtured and supported, so that you don't have to just look and see if the perfect team skill set is there already. You can build that skill set. Okay. And finally, they hold themselves accountable for results. So why teams in medicine? Like, why is this even important? So the country doctor who's working by him or herself is not working. It's not a viable model these days. We have a lot of specialists these days. You know, my division chief, when I was a fellow, would say that pretty soon we're going to have a pediatric cardiologist for 8 to 10-year-olds who are left-handed, that sort of thing. You get the idea. We have a lot of specialists. A lot of care is fragmented, and so everybody needs to be working everybody needs to be working together. When I say patient-centered care and administration, what I'm saying is that for patient-centered care, we have to also look at patients and families as part of the team, because you can say they're healthcare consumers, they're consumers of healthcare services and such, but at the bottom line is that they were an integral member of the team that's going to make sure that the child is healthy. And so patient-centered care is all about partnership with families, and that's again something else we can talk about at a different time. But we have to think of is that so much of what we do really involves health literacy, understanding, commitment, buy-in, and this really starts to get into things like, do they understand and can carry out instructions of the hazmat action plan? Are families committed to coming to their appointment so that we don't have to chase them down and we don't have a big no-show rate? So we have to think about patients as an active member of the healthcare team, because so much of what healthcare outcomes involve depends on the buy-in of the patient family. Finally, that there's a huge administrative role that goes on payers and systems and such, especially since we have so many moving parts of the healthcare system. So there is just absolutely no way that one person or even two people can do it alone. So we have to think about this team of healthcare providers. And finally, this is the italics is something I put in. A high-functioning team is more than the sum of its parts. Okay. So the way, for example, and you'll recognize the situation. We have a child taken care of right now, where, you know, the nurse got the records, I interpreted what's going on, we cleared the child, see how the child's doing medically. You know, we had a hospital social worker and then, you know, DCFS and such. We're all putting, you know, the team puts everything together and says, okay, this is the full picture of what's going on with the child. Each one of us could not do it alone. So to say that, when you're saying it's more than some parts, we're using the team to get a full picture of what's going on with the child and family. Okay. Advantages of a team. What are some of the advantages? It involves people, right? So you get buy-in. You can distribute the workload. So I talk about how we're not really looking at delegating, but you really can get done more if you work in teams. Capitalizes on diverse skills and knowledge. Remember, everybody's got their own skills, everybody's got their training, everybody's got their gifts, and it capitalizes on the talents everybody has. It also broadens your perspective of what's really going on with health of the child. So bringing back to what determines health, everything from the actual medical condition to the process to nutrition to the health literacy to transportation. So this really broadens perspective of what's going on. Provides development and learning opportunities. I mean, you know, we're all learning every day from the folks that we work with. And finally, we can just get more done. Okay. There are disadvantages of a team. You know, so it's not all roses. There are disadvantages. It can be difficult to structure. I mean, you've got to pay attention to the structure of a team because you can have really, really dysfunctional teams and they'll just make life really hard. They do take time to develop, which is why we're talking about it today. And they can be high maintenance, because you got to put some effort into cultivating relationships and make sure everybody's on the same page. Worse is that they can be inefficient or dysfunctional if you don't do it correctly, if you don't do it well. And it can require more time and resource commitment. You know, the idea is that you make the team greater than the sum of its parts so you can achieve more. If you don't do the team correctly, it can really drag you down. And I think that's the danger. So I do think that, you know, you hear the term working in silos, right? So working in silos is just going to create more work. If everybody's expected to work in silos, then it's just the sum of its parts. If everybody's working in silos and expected to work together, then it's going to create more work for everybody because now people are going to start pointing fingers. However you break down the silos, that's where the real advantage, that's where the real work gets accomplished. Okay. So I like asking this question. What are teams that you belong to? Now think about not just in your professional lives, but in personal situations. What are teams that you belong to? Okay. So, and I'll go first. You know, I am a member of a parenting team. So that's my family. I am a member of a research team or a couple of different research teams. I am the member of a clinical team, at least several different clinical teams. So you can obviously belong to more than one team, and I want you to recognize that. You know, I work in a continuity clinic, I work in a medical home clinic. I have an administrative team that I work with. I work with several researchers, so we're a team of researchers. What are other teams? Those are professional, but as I said, I'm a parenting team, and you know, I've got a team at church. I've got a team, I was in a kickball team until our team disbanded. You get the idea. What are some of the teams that you belong to? Go ahead. Baseball team, softball team, kickball. What are teams? Just tell me what teams that you belong to anywhere. That's a great example. And see, and there are roles, and I'm not saying what kind of roles in anything, but you know, you recognize if you think about the team that you have, what I want you to do is recognize the roles that you play within within that team. And everybody teens? Your work settings? Nursing team? And so a lot of these teams can overlap too, because you may have different teams with different identities, different purposes. What other teams exist? Referral, yeah, there's a referral team.
The nursing team.
Yeah, yeah. But think about the relationships you have with each other. What else? What other teams are there? Did you create teams under the PCMH?
We created a quality improvement.
You created a quality improvement team. So it was like a specific team of individuals getting together for the common purpose of quality improvement activities. Right. No, it's great. Others? Community-based teams? I'm going to throw one other question here. What teams might you lead? And I'm not going to ask anybody for a specific answer to that question, but you know, there are teams where you're going to be a rank and file member of the team. And actually we'll get into how do you act as a good team member, okay? So I want you to think about, we're all in this together, right? I mean, in a sense that we're all a team here, like we're a team of providers who care for children. Okay, we're a big team in this room, and we've got our individual areas, but we're, in a sense, we're also a team. But you have to think about where your place is in the team and how to be a good team member. There are teams where you're going to be the leader. And I said earlier that that's a different discussion. Leadership is a different discussion. But there are teams where you're going to be the one kind of pushing the agenda and kind of leading and cultivating the talent that exists in your team. So you might call me, you know, if I am the director of the Patient-Centered Medical Home and Children's, that I am the team leader of the team that's rolling out Patient-Centered Medical Home and Children's. And that's a title I accept, and you know, we'll say, okay, this is my role as a leader. But there's also teams where you may not be the designated leader, but you may be the leader who's actually kind of pushing things. Because the leader may be a manager or not a leader. You ever heard that there's a difference between a manager and a leader? Just kind of think about that as well. Just kind of think about your roles within these teams. Okay. So when we talk about care teams in healthcare, I mean, it's not sufficient to just say this is Dr. Smith's patient, because there's so many different aspects of population health that we manage. We talked about population health aspects. Care teams offer the opportunity to do population review. I mean, at a minimum, we're talking about population health. You're talking about reviewing the entire group of kids and families, but one person is not going to be responsible for all of that. Right? Somebody's got to put the list together. Somebody has to review. Somebody has to make medical decisions. Somebody has to enter everything in. And if you have one person do that, that person can spend all day on 50 kids. And we don't want to do that. But care teams also offer an identity for patients and families. So, you know, there are times when they know they have to reach the physician. There are times when they know they have to reach the nurse. There are times when they want an appointment and they don't need to reach the physician or nurse, and so on and so forth. And it creates an identity for them to know exactly who they need to work with. If you're talking about a very small office, the entire office is a team. If you're talking about a larger office, it creates teams that are smaller than that are within the office. In healthcare, you will see that the minimum, when you hear about care teams, the minimum, usually they talk about a physician plus a nurse. I'm going to ask you to expand that definition when you think about your processes, but generally when you're talking about population review, most people are saying physician plus nurse. Just kind of keep that in mind. And so the team tasks that you may want to think about and define include who's going to review the data. Now, note here that I've put in 3 other steps, main steps. Huddles, okay? Huddles mean that the team actually has a designated time where they sit and talk about what's going on. And it could be anything from a sit-down meeting that takes an hour to a 5-minute encounter hallway, say, let's touch base about what's going on. Huddles are really important because, and even if you don't go through everything, huddles are really important because it says, okay, this is what we need to take care of right now, and this is make sure that we're all on the same page. It's very important for relationships. Remember that teams involve cultivating relationships and having a common purpose. If you don't have the huddles, it's kind of hard to make sure that you're all on the same page. Protected time. Teamwork needs from protected time, and teams need cultivating, teams need attention. To be able to achieve what it needs to achieve, you need to be able to nurture teams. And so there has to be some protected time for the person that's really leading the team at the very least. And when I say action steps, what I mean is that a team has to have defined action steps that you follow, that you agree on and follow, so that everybody knows what each other is doing. We are going to go through a little bit more kind of booky stuff. Team member requirements. To have a high-functioning team, you want to have the right mix of skills. So when you're putting together a team of providers for, let's say a group of 14 to 18-year-olds, you probably don't want too many colleges on there. Just very basic thing. So you want to have technical or functional expertise, but think about who can problem solve. Think about who can make decisions. Think about who has interpersonal skills. Because again, that's part of having a high-functioning team is to make sure that folks can relate well to each other. But skills can be developed, and I would encourage folks to think about teams based on potential as well as actual track record, because these skills of interpersonal skills and decision-making skills can be very developed. Okay. How are you an effective team player? So let's say that you're looking at your huddles, your patient reviews, you've got meetings, you want to go over things, you identify things that need to be addressed. How are you an effective team player? Okay. First is that you want to be prepared. Okay. So anytime you have to sit down with somebody, it's better to just kind of sit down and think, okay, what do I need to cover? You want to be a prepared team player. 2 is to actively participate. So if we're sitting in a meeting and you're the really totally quiet one, it's hard to be an active team player. So it's okay, but I think that comes back to not being afraid to speak, not being afraid to contribute. Because if the team is put together right, everybody's got a complementary mix of skills, and so nobody needs to stay quiet because everybody's voice needs to be heard. Here's a simple one. Keep your promises. If you say you're going to carry something out, it needs to be done. Very simple, but it's harder to trust that a team member is going to do their role if they can't keep their promises. Keep a positive public persona. So anything differences that need to be hashed out, they're back. And they need to be dealt with, and they need to be addressed, but in positive public persona, pick your battles. Be honest, but be diplomatic. Just a few more points. Collaboration and teamwork. So how do we work well together? Use language that draws people in. Just talk about how fun it is to be able to work in a team. Find common grounds for mutual benefits. And I put in conflict management. I'm not going to spend really any time on conflict management, but I will say that what's interesting about conflict management is that when you do leadership and you do team management and you look at processes, there are entire books on conflict management, like literally books on just that one aspect of teamwork, and that's how important it is. So if we're looking at kind of office dynamics or people working together, somebody needs to be really well trained in conflict management. And it's just a very important part of it. Okay. Actually, you can ignore the exercise part. That was an old slide. Beware of pitfalls. Beware of the ego trap, which is that so-and-so always knows best, and so we're gonna follow that direction. That's not the way a team works. Beware of using a team for self-promotion, because it's about the team and not the individual. Make sure that you are an attentive listener when somebody is speaking in a meeting or working with a team member. And beware of not interacting with the team that you're working with. So, and this is why folks who, when you do leadership and team training, that they really get into, you know, how often you see people, when you see people, cultivating just positive reinforcements, little, gifts, parties, social, that sort of thing. And that's very important for good teamwork. Okay. And finally, I want to mention this a little bit as a team leader, not because I'm asking everybody to go in and lead something immediately, but I do want to, you're all going to find yourselves in situations when you've got an idea and say, okay, I want to push something through. Okay. And when you're a team leader, or if you just have a great idea and a team says, okay, please help us make it happen, you're going to find yourself in some sort of a leadership position. I use this slide to make sure that you're empowered, or you've got the tools, or have some idea about how you want to get something done, or be able to move something from here to there. Okay. As a team leader, you establish urgency and say, you know what, we need to get this done. We need to get it done by a certain period of time. Now, you may, in the context of this PCMH program, you may be the person, for example, who's making sure that we keep to our deadlines. This attestation needs to be done by this period of time. Let's make sure we know how to get it done. Establish the standards and direction with compelling context. One compelling context is that if we get this done, we'll maintain our support payments. If you don't get it done, we may lose our support payments. So, select members with skill and skill potential. So there's that potential word again. Pay particular attention to first meetings, because that's when you really set the tone and say, okay, we really got to talk about this PCMH. We really got to talk about this performance standard. Set clear rules of behavior. So, if you're in a meeting and you're looking and you're discussing what we need to get from here to there, there may have to be, sometimes it helps to do clear rules of behavior on who speaks and when it speaks, and you have to kind of pay attention to that. There are even things like where you sit, in a meeting, kind of relative to the door, so that establishes you to say, okay, I've really got control of this meeting, just as an example. Challenge the group with fresh facts and information. Okay, so one of the things I'm doing here, I'm challenging you, I'll tell you what I'm doing here is challenging you to think about how to transform the way that we deliver healthcare, child healthcare, in the context of every payer I know in this country is talking about rewarding primary care for doing population management. This is where the money is going. Every payer is doing this, but they don't know how to do it. It's up to us to tell them how it's going to be done. Okay, this is our compelling context. Spend lots of time together, and don't forget the importance of positive feedback, recognition, and rewards. Questions? Is this interesting stuff? Is it useful? I think that when we're talking, this is such an important part of delivering healthcare that we don't really talk about it, I think, as much as we need to. You hear about care teams, and I wanted to be able to give you a context of how the team is supposed to operate. Okay? Because we can talk about the roles and we can talk about the assignments, but I want to talk about how to operate. But this is really about operating teams. Okay.
I have a practical
Go.
question or comment related to building teams I have some experience with. So in an old role, we were trying to develop high-performing teams, right? And we had a fairly large clinic that had 5 providers, and if you looked at what each of those teams did, they operated different levels of efficiency. And what we learned was it's because what the nurse felt like he or she could do versus what the provider wanted them to do was often different. So I can't give that shot because I can't make that order. Or you know, he does that, I don't do that. That kind of thing. So, and so one of the tools that we try to implement, because it's a process, is just office protocols for different conditions, situations. So I was just curious if folks are experiencing that issue. Okay, I'm trying to develop a team, but I don't know how to do it. Or I got these other, you know, I'm not allowed to do that, so I'm not empowered, you know, to be a high performing member because so-and-so won't let me, or something like that. So just curious.
Yeah, it's the, one of the, I'm thinking we should probably talk about leadership at some point. I don't know if leadership in context of teams or healthcare is really discussed, but one of the topics I've been long interested in is how to lead from the middle or how to lead from behind. You know, because a lot of the leadership, what you're really talking about, in my opinion, I think is a leadership issue. You know, and it's leadership in forming teams, leadership in kind of setting a new direction, and it's a lot of the leadership guides I've seen are written by people who are in recognized positions of leadership. Although you could equally call them, say they were top managerial positions and they're not necessarily leaders, but you know, they're written by like directors and CEOs and such like that. And the simple answer is most of care transformation, most of quality improvement is interpersonal. You know, and I think they'd say that 80%, at least 80% of making a change is interpersonal. And if you're not at a point where the care team if you're not at a point where there's sufficient buy-in from influential people to have a care team, to have like a team-based process, then I would try to really push the team concept because you can't make it work. To really have that sort of change successful, you need to have leadership buy-in, and that's probably going to take a certain amount of, I would actually move over to the change concept rather than the team concept, because the change concept there is that you have to get leadership buy-in, leadership push, and leadership tone before you can really move in that direction. I don't know if that's kind of answers the question, but I think that's I recognize that there's situations where it's difficult and not possible to get the team to where it needs to be. In that case, you step back and say, okay, who are we missing? And what we're missing here is an effective tone from the leader. And if a clinic leader is not giving us the right tone, then we need to work with the clinic leader. Other observations, questions, reactions? Okay, so we're on time. And I think we're up for our next speaker. We appreciate Amy Murphy's willingness to speak about their experiences with teams. I'm happy to do that.
this year we included, gin, Depo-Provera, acne, migraine headaches, and some others. And then we also, our physician, she is responsible, she has created templates in our EHR, which is included mental health, asthma. She's updated our well child checkup and obesity. She's working on, age-appropriate AAP guidelines for lab and developmental screening, and she's also working on Down syndrome. The second thing that happened that really helped us move forward with the PCMH model was our care teams. And that's on our next slide. This is how we currently are working with our PCMH. As you see, each provider has a nurse and a front office staff member. After attending a seminar and having discussions, we decided how to enhance the provider-patient relationship. We determined that each provider needed to have his or her own nurse and front office staff. We then assigned a nurse and front office staff to each provider based on who had worked with the provider in the past. We have 9 of these teams now. The process begins with the front office staff and continues with the nurse and ends with the provider. On the next slide, we have our job description for our front office staff member. They are, I've summarized it, but these are all the items they are responsible for. They are to maintain an up-to-date list of the provider's PCMH patient. They are to keep track of all needed appointments. They know that their patients are to have a yearly well child checkup and a problem-driven encounter at least every 6 months, and more depending on the severity of the problem. It's also the clerical staff's responsibility to arrange timely appointments, and they should coordinate this with the nurse and provider. They also need to devise a system to notify patients of needed appointments. They need to make sure all of our patients have a flag in our EHR. It's imperative that each patient have an email. This is a way that we may send Vanderbilt's asthma action plans, and also we're moving forward our patient portal. We also have our front office staff note the patient's school, grade, teacher within the social history on the base sheet. We also document the email or fax number, and also if the child is in a daycare or just their child care arrangements. We are also doing clinical alerts in a patient care team. That's all documented in our EHR, and our front office staff is responsible for also putting information about special ed clinics with the PCMH patient uses. It's also the responsibility for them to put all correspondence in the EHR and just to keep the lines of communication open between all the team members. We keep track of our 10% with a flag, or 10% of our high priority beneficiary with a flag with green light. Each day, Leanne, she's one of our front office staff members. She's also on our PCMH committee. She runs a flag report for those patients to be seen each day. It's given to the front office staff who's been assigned to this patient, and the planning process for the appointment begins. The report is reviewed for the PCMH items that need to be completed, such as the well child checkup. Each PCMH patient has a flow sheet that works as a checklist with individual tasks that are marked as completed and helps determine how the patient is progressing with his or her plan of care. At any given time, this flow sheet can be assessed to see the patient's status in relation to PCMH goals. And the next slide is, we have examples, and these are all fake charts, so this child really hasn't had too many well child checkups. But we have one that's just a very generic PCMH, and on this we keep track of well child checkups, and our major diagnosis, it'll be like the recheck of ADHD, asthma, obesity. Of course, this has where our care plan is created and updated, and just any kind of miscellaneous information that we can type in on this. On the next slide is for our ADHD. On this is where we keep, again, a recheck, the care plan, and some of this information overlaps, but you can click on any of these items and get this information. This is also where we keep track of our Vanderbilts. On the next one is our asthma. You can see where we keep track of our rechecks, our care plans, PFT or asthma control tests, asthma action plans, also to keep track of their flu vaccines and again, miscellaneous information. We also keep track of obesity, well-child checkups, obesity rechecks, care plans, and benefit panels. Once the office staff has determined what needs to be addressed on that particular visit, she passes it along to the nurse on the PCMH team. The nurse plays an important part in the process, as you can see in the next slide. Again, I'll summarize this, but each nurse has a job description on the PCMH team. Again, they can work with their front staff member to maintain an up-to-date list of their providers with PCMH patients. They kind of coordinate with the front office staff member to for the appointments for the patients. They also, the front office staff, they keep track of all the emails for the patients, but also the nursing staff helps with that as well. They also help keep track of all the patients' school, grade, teacher, daycare information. Also, we are doing the clinical alerts for PFTs, also flu vaccine for asthma, and that pops up when the visit is being created, and the nurse alerts our providers for that. And then also the nurse helps, we have our patient care team, which is our base sheet, and our nurse is also helping with that, keeping that data up to date. The nurse's main responsibility is to update the medication list. They are to note the name, the strength, the dosage, and frequency of use. They need to make sure they have complete information. They also need to know if the medication has been discontinued and the reason why. And they also need to help their provider keep an up-to-date problem list. When the provider meets with the patient, he or she is now equipped with all of the important information needed to treat the patient. The provider documents the reason for the visit and updates the plan of care based on discussions with the patient, patient's family, and other healthcare professionals. This healthcare model includes all areas of a patient's health, medical, behavioral, environmental, etc. An assessment can be made and treatment is prescribed. The treatment plan and follow-up are then documented for future visits. Assessment of progress is the final thing to document. This will assist the team in knowing what needs to be done to further help the patient. We also have a job description for our providers. Again, a lot of this is repeats, and then a lot of it is what our nursing and our office staff do. But they at all times know they can go get a list of their PCMH patients. They also know they can go and see when their patients are due for any kind of checkup. And they also know they can refer to any of this and know what duty any of their team member, what the duty of their team members do. And they also know to work in conjunction with their nurse for an updated medication list. They also know to work in conjunction with the team members for clinical alerts. One of the primary responsibilities for our providers is to keep an up-to-date active problem list. They need to address each active problem list within a problem-based visit or well-child checkup. Therefore, it is important that they know a problem is resolved or inactive so that they will not be required to address it within the night. They also are to alert Nikki, who's our care coordinator, that they want a patient for a future PCMH as of, now 2016. And they also need to tell Nikki if there's a patient they want removed. Again, the documentation is our key thing that they need to do for PCMH. So they need to assess the progress achieved or not within each active problem. Also, templates are a big thing, and again, our physician champion is one who's working on all our templates within Renee, our EHR. So good things to come out of our teams with PCMH. It's more continuity. In the past, the patients could be seen by any of our providers that was at the clinic on their appointment day. With the PCMH model, we try to see the same provider and nurse now. The same front office staff interacts with the patient while at the clinic and handles any Emerson front office staff has been assigned to a patient, the patient now has someone specific to speak with when he or she calls. If they have questions, he or she can call and ask to speak to his or her nurse. So not so good things that come out of our change. It only works as well as the data that is entered and organized. If the staff isn't organized or doesn't enter all the pertinent information, the outcome will not be as good. In conclusion, PCMH teams have been a good tool for our clinic. It has improved communication among the staff as well as with the patient. It has organized the day-to-day duties into a streamlined process. By doing this, the staff are more invested in the patient. Instead of just doing a task, the staff is performing a step in bettering the patient's health. Instead of treating a patient for the immediate issue, the team is looking at the big picture of the patient's health. The patient is treated for the immediate problem with the future in mind. The medical aspect is not the only thing that is considered. The behavioral, environmental, educational aspects are also taken into account in the treatment process. Education is one of the key points of this model. The more a patient is educated and the more educated a PCMH team is on the patient's life, the more the team is able to help the patient live a happy lifestyle.
Awesome, thank you. Are there any questions for Amy? Amy, I've got one question. You mentioned a lot of different processes, and I think those are fantastic. And I'm actually partly interested in just how long it took to develop all of that. But my main question is whether you're able to follow how often those processes are being completed, because there's a lot of different processes that you've worked through. I mean, what's your sense? How did you develop a sense as to how well they were being adhered to? Right? Or do you have a sense of how well they're being adhered to? Such as, like you mentioned, the provider updating the problem list.
Well, we have a care coordinator, and actually she is, that's all she does is PCMH. So she runs reports pretty much every, Nancy runs them every week. So she's keeping track of all of this stuff.
Okay.
I would say this all got started last August. I mean, as it goes on, I think it runs better and better.
Sure.
I'm not saying it's perfect,
Yeah.
because, I mean, there's times that we overlook something or something doesn't get entered correctly. But overall, it's getting better and better, and the data we have is.
That's great. So you've got an ongoing feedback loop, and there's somebody that's whose job it is, whose task it is who is tasked with providing that feedback loop, and I think that's key. And you recognize that it rolls out, it doesn't all just happen at once. And I think that's great. That's awesome. Any questions, thoughts?
Now, do your patients, when they come in, how you've got them assigned to this patient, to this doctor, to this nurse, to this front desk, what if that physician's not there? Do they see other providers?
Well, yes, that will happen, especially if it's a sick visit, that's just gonna happen. I mean, but if it's a well, or if it's something, of course, for their asthma or ADHD, we're gonna do our best to get them in with that provider. But if it's an on-call situation, if time allows, then yes, we're still gonna tell that provider that day, hey, this is a PCMH of Dr. So-and-so. They've got this, and if time allows, yes, they still go ahead and update the information and everything.
Because, with that aspect of them seeing, others for the sick visits, we're told, okay, you need a care plan, you need to address this care plan. Some of our doctors still, I'm stepping on this other provider's toes. Why should, I'm seeing this kid for an ear today, but I don't need to be digging into his ADD, this is how he's prescribing, changing meds, because then you open a huge can of worms. So we didn't know if by, your team being divided out, if everyone shares the roles, even if they
Not for
see someone else.
ADHD, only the ADHD provider is that person who follows for that. But I would, maybe asthma, I'm not sure what kind of problems, sometimes you just kind of jump in and go ahead and do a little bit of action for it. If they follow up with your PCMH provider at 10 days, 30 days, whatever.
Yeah, one thing I would kind of point out there is that if you look at, there's all these overlapping kind of your team that a child and family are going to see, but what you're referring to is a team of providers, right? And so they're working together as their specific role, but it sounds like that's somewhere that would be worked out within that. If you see the team of providers as a team, then they would work that role out. I would say that if a child's in for a nerve infection, then yeah, I wouldn't manage the ADHD unless the parent brings it up. In which case, then, but then the appropriate role might be to make sure that they follow